Hi, thank you all for coming. My name is André Lindsey. I'm an Associate Health Fellow at the Edward Hines Jr. Veterans Affairs Hospital. And today I'm going to talk to you about a population that everyone here is familiar with, that everyone here knows, but a population that you likely don't routinely discuss. Today we're going to talk about disorder of consciousness. And when I talk about disorder of consciousness, when I talk about DOC, typically the first image that comes to mind is an individual in a coma. Because when we're talking about disorder of consciousness, we're talking about a change in cognitive state. When we talk about DOC, we're talking about a population that is not continuously displaying cognitive behavioral function. We're talking about a population that is solely dependent on caregivers, on family members, and healthcare providers to help maintain their medical stability, but also to advocate on their behalf. And DOC is a growing problem. There are roughly 27,000 new cases of DOC each year. DOC is frequently the result of a traumatic brain injury, or TBI, and we know that the number of TBIs has been on the rise. Between the years 2006 and 2014, there was roughly a 53% increase in the number of traumatic brain injuries. With respect to our military personnel, we know that TBI is higher among servicemen and women, and that between the years 2000 and 2017, there were roughly 350,000 traumatic brain injuries sustained by U.S. servicemen and women. And though most traumatic brain injuries won't result in a disorder of consciousness, and many won't result in a loss of consciousness, for those that do, this results in a substantial shift in life that not only impacts that individual, but also substantially impacts their family members and loved ones. And that, coupled with the growing number of cases, is a reason to further examine it. When we talk about treatments for this population, when we talk about assessments, we're talking about medical stability. Assessments look at baseline cognitive functioning, and treatments target preventing injuries from getting worse, reducing swelling, reducing bleeding, reducing pressure, preventing anything that can cause medical decline. Oftentimes, we see high inpatient care costs. Worldwide, they range between $2,000 and $400,000 in inpatient care, and with a mean of roughly $88,000. And this doesn't take into account lost wages. This doesn't take into account outpatient care. This doesn't take into account all the other changes that occur with a massive medical incident. Currently, with respect to treatment, Dr. Teresa Pape at the Edward Hines Jr. VA is looking at repetitive transcranial magnetic stimulation. Our lab has been really focused on how this can be a potential tool to aid neurobehavioral functioning, and using magnetic pulses as a means of potentiating a neural environment that is responsive to change that may aid recovery. With respect to the proposed assessment, we are intending to incorporate EEG as a tool to measure neurological changes in response to treatment, so in response to the use of repetitive transcranial magnetic stimulation, and to assess the likelihood of recovery. And this is based on a growing body of evidence that EEG, specifically evoked response potentials, can be predictive of recovery in the DOC population. And so an example of that is hearing one's own name can result in a positive waveform at roughly 300 milliseconds. So Amber, Ashley, Jacob, Michael, David, and if your name is David, you hear that, and we expect to see a positive waveform, a robust positive waveform at roughly 300 milliseconds. And for individuals with a state of DOC, this waveform is frequently present in those individuals who are likely to recover. So there's a growing body of evidence to show that, but this is mainly being used in a research setting, and the goal is, why can't this be used in a clinical setting? Like, the goal is to change that. And so really repurposing that and modifying that into a clinical assessment that's openly available. So looking at response to one's own name, but also looking a little bit past that and saying, let's look at a higher level cognitive task. So let's look at response to syntactic errors, or let's look at syntactic incongruity, which is a P600, so a positive waveform occurring at roughly 600 milliseconds, and creating a standard template that can be used for both researchers as well as healthcare providers to assess function. And so again, this is going to be part of an ongoing clinical trial. And what we want to do is establish neurotypical data, establish that prototypical response that you would expect to see, looking at individuals of different age ranges, of different sex, and as well as looking at that within individuals who have a DOC, and again, fine-tuning that predictability response, seeing if we can get that, how well that response is predictive of recovery, and matching what we're seeing in the literature. And that's going to be really where the budget targets. Getting that neurotypical response and matching the neural response with the time lock stimulus. And this work is currently funded by a congressionally directed grant. And with the additional funds to really further examine the use of EEG as a clinical assessment, whereas the current funds are really targeting that use of repetitive transcranial magnetic stimulation as a treatment tool. Our team is comprised of myself. I am a postdoctoral researcher, as well as Sherry Livingood, who is an auditory neuroscientist who focuses heavily in neuroimaging techniques, and Teresa Pape, who is a clinical neuroscientist who specializes in disorder of consciousness. So myself, Dr. Livingood, and Dr. Pape will really spearhead this endeavor. And the overall impact is to aid patient care decisions. We really want to provide researchers and clinicians with more insight regarding the use of EEG, ERPs as an indicator of cognitive function, as well as looking at potential for recovery. And to make this more openly available, because again, right now it's primarily a research tool and not really a clinical, or at least not really a clinically used tool. And it's one that has a lot of variability. And I think if there was an open standard access tool, more individuals would be willing to use it. And so with this population, it does take time to grow the sample size, but having a more standardized template will really aid the number of individuals who have access to it, allowing for better care decisions, allowing for families to really plan for what their next step should be, allowing for a better idea of long-term recovery. So thank you all for coming. Thank you all for listening. And I look forward to your questions.